The entire concept behind the MARC is to facilitate single appointment delivery of the appliance in about an hour. Much or all of it should be delegatable to experienced chairside assistants. Select a crown and try it on. If it is too large, it will hurt the gums and be too loose. If it is too small, it will not go all the way down, even with a bite stick. You can usually assume that the other three first molars are the same size as the first one, but you need to try them all on. If a crown is a little loose, crimp in the mesial and distal margins using your tweed arch bending plier. Once all four crowns are fitted, have the patient bite in a nearly end-to-end incisor protrusion with the incisor midlines aligned. Check to see how much distance there is between the mesial of the upper large square tube and the lower buccal arm. The distance should be at least 4 millimeters on both the right and left sides in order to allow space to insert an elbow. The space should not exceed 8 millimeters, or the elbow will be levered too long and may cause breakage of something. In general, refrain from trimming the stainless steel crowns shorter, as too much retention will be lost. Once the crowns are fitted and the correct rotations are known, remove them. The lower crowns must be stabilized to prevent them from drifting and rotating mesially. This can be accomplished by braces in the lower arch or by a lingual arch. If braces are used to stabilize the lower crowns, the minimum lower appliance is a 2x6. And a bayonet bend is placed exactly mesial to the crown archwire tube. If a lower lingual arch is used instead, it may be soldered, but it should be inserted at this first appointment. When checking the patient in Class 1, there are several things to check. You must check to see that the lower arm does not stick out into the cheek excessively far, and you must check that the upper elbow is torqued in tight against the lower buccal surface. This graphic shows that the upper elbow has been torqued in tight so that it's touching the buccal surface of the lower crown. The next step after checking the patient in Class 1 occlusion is to check him in Class 2 occlusion. Have him retrude his mandible and make sure that he cannot bite behind the elbow. As he comes back, he cannot slide off the distal end of the sweepback arm. You have to make sure that the sweepback arm is long enough that the lower arm cannot bite behind the sweepback arm. You also have to make sure that this lower arm does not get back up under here and work its way into the interior of the elbow. The key is to make sure that the sweepback arm is long enough and bends up like this so that the patient cannot bite behind it. This demonstrates why you must keep the upper elbows torqued in tight. When the patient goes into retruded mandible position in Class 2, if you don't have the elbows tucked in tight, the lower arm may be able to bite inside of the upper elbow. You could see here that if the upper elbow were torqued out toward the cheek instead of torqued in tight, that this potentially could bite inside the elbow and then it could get locked there. If you have a severe Class 2, you may only want to advance them halfway initially and hold them there for 6 months and then advance the rest of the way 6 months later. Because if you advance a severe Class 2 all the way in one jump, theoretically they may be able to bite posterior to the elbow when they retrude back into Class 2. For cementation, first sandblast the interior of the crown. They come pre-sandblasted, but an invisible oxide layer may have formed while in the box. A self-curing cement such as Protec may be used. You can also etch the teeth to increase retention. During cementation, excess cement will escape out the occlusal hole. Once the cement is hard, try in some elbows. When the patient bites end to end on his incisors, if there is a posterior open bite, you may need tall elbows. Use the torquing tool to flare the vertical leg of the elbow buccally enough to bite outside the lower crown. Use the shims to position the elbow far enough forward to maintain the end-to-end incisors. You may need to bend the horizontal or vertical elbow legs with the short beak 3-prong plier to get the bite just right and cheeks comfortable. The distal end of the horizontal leg of the elbow should extend 3 to 4 millimeters distally out of the large square tube to allow for tying in the elbow and to provide room for more advancing shims later if necessary. But the distal end of the horizontal leg should not extend more than 4 millimeters distally to the large square tube, or it will cause cheek sores, especially if the upper 7s are unerupted. Tie the elbows in as follows. Twirl a steel ligature so it is 2 strands thick. Single strands seem to break. Give the patient a copy of this handout. Show them in a mirror how good their face and especially their chin looks. Remind them this is instead of a headgear. Explain that the arms or elbows will break if they bang on them. The arms are only there to serve as guides for where to bite, not to be chewed on. Expect to see some increase in overjet between appointments. Add shims to the elbows if necessary in order to keep the incisors end to end. See them every 3 to 4 months. After 1 year, get tomograms of the jaw joints to see if the condyles are reseated in the fossa. Expect slight relapse and overcorrect to offset it. After removing the Mara crowns, it will probably be necessary to bond or band the molars for detailing prior to overall band removal.